congestive heart failure. Okay. Another case, 9 years old, male, presenting with fast breathing. This patient is grunting, coughing for 5 days. He has been seen 2 days earlier with steroids and bronchodilators. This is his vital signs, and this is his examination, cardiac examination, general and local examination. Heart rate is very high for his age, 150 is very high for a 9 years old. And the blood pressure is within normal, respiratory rate is mildly tachypnic, and temperature is just 37.5. We have manual wheezes, and the heart sounds are muffled. Muffled heart sounds need experience. You need to know the normal to be able to distinguish it from muffled or abnormal heart sounds. But significantly muffled heart sounds cannot be missed. They are easily recognized, okay? And we can hear a systolic apical murmur. So, what is this? Penny? What is that? Who is with pneumonia? Who is with pneumonia? Raise your hand. طيب في دكتور بيقول secondary pericardial effusion. ايه اللي يخليك هنا تقول pericardial effusion؟ Sounds in pericardial effusion are distant and not muffled. And there is a difference between muffled. عارفين يعني ايه muffled؟ يعني decreased. Okay? Distant are different. You can hear that something is strong, but it's far from you. But weak is something different. So different is not tight. Who is with pericardial effusion? ها؟ طيب مين عنده أي اقتراح ثالث؟ ها؟ السمع. مايترال ريجيرج ليه؟ أنا موافقة في مايترال ريجيرج ليه؟ ليه عنده mitral regurg؟ ما هو الابيكال ميرمر ده representative of a mitral regurg. I agree. ليه عنده mitral regurg؟ ها؟ Congenital hypertension at 9 years old. Rheumatic fever, I would have a history of what? Repeated? Not necessarily, but it can be. I have to have a history of arthralgia or arthritis or documented rheumatic fever. Okay? So what else? Muffled heart sound, this is a clue diagnostic at any exams for حد قال هنا حاجة myocarditis. Okay? So muffled heart sounds is diagnostic for when it is acute. It is diagnostic for myocarditis. المايوكاردايتس بتعمل ايه في الهارت؟ ادت الى impairment في الفانكشنز اللي ادى الى الهارت فيلير. هو يعني ايه هارت فيلير؟ هنيجي بعدين عشان نشوف الديفينيشن بتاع congestive heart failure. يبقى ال 2 patients, ال 2 months old وال 9 years old both have congestive heart failure. Congestive heart failure وكل الاسامي اللي احنا قلناها دي ككاردياك emergency, they are not diseases. They are a clinical finding or a clinical situation, clinical conditions. It's not the diagnosis. It's a clinical situation or clinical condition of the patient. So it's not the etiology. Congestive heart failure is not an etiology. It's a term that represents a clinical condition as a result of an etiology. Okay? انت في الاي ار مطالب انك تعالج الكونديشن اللي قدامك. مهم ان انا اعرف الاتيولوجي. يس اتس امبورتنت، بس في حاجات هيبقى مهمه قوي عشان اعرف الاتيولوجي، وفي حاجات مش مهمه خالص. يعني انا هجيلي عيان congestive heart failure هعالجه كcongestive heart failure بالحاجات اللي هنقولها whatever the etiology. اوكي؟ هيبقى في شويه اضافات بسيطه related للاتيولوجيكال فاكتور اللي ادى الى الcongestive heart failure. اتفقنا؟ congestive heart failure هو ايه؟ The physiological status in which the cardiac output is not able to meet the tissue requirement. وقلنا الكاردياك output عبارة عن stroke volume في الهارت ريت. طيب الستروك فوليوم زي ما قلنا في 3 كلمات لازم نفتكرهم. الستروك فوليوم بيعتمد على البري لود والافتر لود والكونتراكتيلتي. according للديجري بتاعة السيفيريتي او الديبليشن of the circulations والinadequacy of representation or fulfillment of tissue requirements, it can range from sudden death دي acute severe ويعمل sudden death، يا اما acute heart failure ويؤدي الى respiratory failure ودي الحاله اللي بنسميها acute pulmonary edema، او acute heart failure وادى الى circulatory failure ودي اللي بنسميها cardiogenic shock، ودي غالبا خاصه بحاجات mostly او most of them are cardiac، يعني cardiac lesion usually are the one who leads to cardiogenic shock. او it can be only a heart failure. And heart failure is a clinical, can be preload failure, okay, in which هزود ولا نقص البريلود؟ هزود البريلود، فزود اللود على الهارت. ايه الحاجات اللي تزود اللود على الهارت؟ الليفت تو رايت شانتس زي البي اس ديز والبي دي ايز والفيستيلا، او السيفير انيميا بتعمل سورت اوف هايبر دايناميك سيركيليشن، فيبقى في لود زياده على الهارت trying to compensate بس actually it cannot فيخش في هارت فيلير. او contractility failure، والحاجات اللي بتعمل contractility failure كتير اهمهم المايوكاردايتس اللي حضراتكم قلتوا عليها، او الكاردياك تامبونات، كارديومايوباثي، كواساكي، او ميتابوليك والكترولايت ديستربنس، حاجات كتيره جدا. او الافتر لود فيلير، والافتر لود حاجات قليله بس very serious. الهايبرتنشن is not common ان هو يؤدي لكونجنتال هارت فيلير في الاطفال بالذات، لكن الكونجنتال بارت زي الاورتيك ستينوزس والكارتيشن اوف ذا اورتا من الحاجات اللي بتعمل افتر لود فيلير واللي تؤدي لنا الى كونجنتال هارت فيلير وايفن كارديوجينيك شوك زي ما هناخد بعدين. او الاريزميك فيلير، العيان يخش في اريزميا. and what is the problem of arrhythmia؟ سامع كده يا دكتوره؟ اوكي اصلا مايك فاهم. What is the problem of the arrhythmia? The arrhythmia heart is not functioning properly, okay? It's functioning but not properly. So, at the end result, stroke volume is not the amount required, the cardiac output is not the amount required. That's why we have arrhythmia end up in impaired contractility or impaired functions, and hence, that can lead to congestive heart failure, and usually this is the presentation in the ER. So, when to present with congestive heart failure? It depends on the lesions. That's why when you have a patient, the time of presentation is very important to the clue for the underlying etiology for the congestive heart failure. Okay? At first, usually severe hypoxia, hypoglycemia, acidosis, hypoglycemia, sepsis, كل ده can lead to congestive heart failure. Yes. The congenital element that can lead to heart failure in day one is the ductus in a premature babies. This is very common in the NICUs. We face that, premature babies. They have a large duct. Large duct will cause a huge left to right shunt and cause a congestive heart failure, and this is usually a problem. Sometimes outside, not here, you need to do surgical ligation of the PTA if the pharmacological closure trials fail. If the patient comes to you in the first months of life, like our patients, our patient is 2 months, okay? It can be one of the severe congenital heart disease. I would expect a duct-dependent lesions, or سواء كان on right side or left side, يعني hypoplastic right heart or hypoplastic left heart, coarctation, aortic stenosis. I know this is difficult for you to understand, but as we go in the lectures, we can explain more, and please ask if you cannot understand anything, okay? And what congenital heart that can present later, like the PSD, like the acquired heart disease, like rheumatic or myocarditis, the many diseases that you have experienced. So, our patient was 2 months old, okay? So what do you suggest this patient has? Okay, heart failure is a clinical triad of tachypnea, tachycardia, congested tender liver. That's why it's a clinical diagnosis, not the etiological diagnosis. Okay? So if you find this, you will treat the same. Whenever you find this triad, you will treat the patient the same, unless you will add something according to the basic or the etiological factor. If we have additional this 3 triad هنضيف عليها شوية حاجات يبقى اسمها حاجات تانية برضه clinical diagnosis. Okay? Acute pulmonary edema. The above الترياد ده severe respiratory distress, wheezes وبازل crepitation. كل الناس عارفة اللي بتشتغل في الاي سي يو بالذات عارفين يعني ايه acute pulmonary edema. يخش يسمع العيان في عيان في severe respiratory distress هيلاقيه crepitation بيبقلل على البيز اوف ذا لانج. cardiogenic shock هم الثلاثة وساين اوف شوك. عارفين ايه هي الساين اوف شوكس؟ prolonged ريفيل تايم كابيلاري ريفيل وموتلينج وبريفري كل الحاجات اللي حضرتك عارفينها. طيب وات تو دو؟ انا قابلت عيان بكونجستيف هارت فيلير. I don't care for the basic etiology. اعمل ايه؟ انا واقف في الاي ار دلوقتي. اعمل ايه؟ wrong. ABC. You have to be systematic. Conditions in the ER are very stressful. You are not only having one patient, you have several patients. This is coming, and while you are doing this, another patient is coming. So you have to be very systematic. And excellent ER physician or excellent ER physicians, they are not the medically excellent. They are the ones who knows how to handle critical situation and be still organized under stressful conditions. وازاي يعرفوا يشغلوا الناس اللي معاهم كويس. Otherwise it's going to be a mess. Okay? So you have to keep calm. If you panic, you will go yourself in a congestive heart failure. So we don't need to in a congestive heart failure. Then you have to keep your eye open because every second in the ER is important for the patient and can change in the patient conditions. That's you have to keep your eye very open, and of course you have to switch your brain on. Okay? So what to do? You have to do the systematic approach, ABCs. Ensure that the patient doesn't have any life-threatening conditions. And we will have, after stabilization of the patient that I have no ABCs problems, I will take history and physical examinations rapidly, and I will start to order for the diagnostic tools which will help me for how to monitor this patient and how to get the etiological factor. Again, what to do? First question to be answered, do they have a life-threatening condition? العيان ده انا هعالجه عندي هنا في الاي ار ولا I have to arrange ان هو هيخش دلوقتي الاي سي يو ولا هيخش القسطره ولا هيروح فين بالظبط؟ يبقى لو انا عندي life threatening condition I have to know the next step. Second question is the patient is cardiac or not؟ لان هل هو لو هو cardiac يبقى ايه مشكلته؟ هتسهل لي الطريق. ممكن يبقى عامل investigations، ممكن يبقى هو على medications whatsoever، لازم اعرف كل الكلام. والسؤال الثالث ايه الانفستيجيشن اللي انا محتاجها علشان ما اعملش حاجات تضيع لي وقت اكون انا محتاجه اكتر من حاجه ثانيه. طيب almost all patients with congestive heart failure will need chest X-ray, we need ABGs طبعا, we need serum electrolytes, and we need investigations to diagnose the cause. Of course, echocardiography now is becoming available in most of the hospitals, and you can easily get an echo. Usually in not there's no many people as we expect to specialize in pediatrics, but it is available and not becoming difficult to get an echocardiography. But we have to keep in mind that echocardiography is not the life-saving tool for the patient. Because sometimes you find the resident rushing at you at the echo department with a patient who is severely distressed and sinuous and in very bad shape, and he would like to do an echo for diagnosis. No, you have to stabilize the patients. After that, you can get an echo departure. Close observations, monitor of the vital signs and chest sound and level of consciousness is very important, because I don't like this patient to go from congestive heart failure to cardiogenic shock or acute pulmonary edema. So the level of consciousness is very important. Then bed rest. Do I need to put the patients in certain position? Yes, this is important for cardiac patients. Patients with respiratory distress, congested lung, will need a semi-silent positions. If a patient coming with, as we will see later, some of them will need to have a squatting position, so it's different from a patient to patient. What type of fluids and foods should I give? What time should I give? This is very important, and when. And oxygen therapy. Is every patient with congestive heart failure need oxygen? Sometimes yes, sometimes no. If you need to keep the duct open, you cannot give oxygen, because oxygen closes the duct. We'll take this later. But most patients with congestive heart failure, the simple congestive heart failure due to overload manifestations, will need oxygen to relieve them and to give them better oxygenation. So, what medication we would expect? I would give inotropes. What kind of inotropes do you know? لا اللي هي norepinephrine. Dopamine is a weak inotropes. Usually we give it for the renal perfusion, just in the 5 mic for the renal perfusion, but it doesn't have a real inotropic effect. Okay, so what else? Okay. What you have said is the new drug. It's not so much new. It's called milrinone. Milrinone, one of the very good inotropes. وهو vasodilator في نفس الوقت، فبيقلل الافتر لود، فبيشتغل على كإنوتروبيك افكت وبيقلل الافتر لود، وما بيزودش الاكسجين ريكوايرمنت. السؤال: اقدر ادي ديجوكسين in acute congestive heart failure في عيان in a critical situation؟ لا. ليه؟ غير ولا ده. هي دي بقى اسمها ايه؟ الايه؟ لا ولا دي، بحسبك قصدك حاجه ثانيه. ها؟ ده سايد افكت. ليه ما اقدرش عيان in severe acute congestive heart failure دلوقتي و is about to compensate in shock ما اقدرش اديله drugs؟ طب ليه؟ عشان ايه؟ delayed onset. انا عندي عيان دلوقتي خلاص، هناخد الكلام ده بعد شويه. عيان now he is, if I leave him now within 10 minutes he can pass away. الديجوكسين will not start before half an hour at least. هقول لكم والسيرم ليفل ما بيوصلش قبل كام؟ يعني ماكسيم، يعني المينيمم تايم اللي انا I can get is 12 ساعة، لكن اقل من كده ما فيش. So نعم، كل دي element ما هياش contra indications ان انت تديه في الاكيوت كونديشنز، بدليل ان انت بتديه في الكرونيك كونديشن او في الستيبل بيشنتس، لكن هي المين ايشو ان انا علشان الانست اوف اكشنز I need something when I put an IV line that works immediately, not works after half an hour. ايه؟ افندم؟ طيب ما هو ده element، بس ده مش الكونترا انديكيشنز اللي بسببه ما بديش الديجوكسين. اوكي؟ وبعدين مش كل العيانين اللي عندهم congestive heart failure عندهم renal impairment، وفي حاجه اسمها، لا مش بالعقل ده باللاب، وفي حاجه اسمها adjustment